Thanks, Howie. Okay, the floor is open. So what do you guys think? 5 years from now, like, we're all working in ivory tower institutions with people like Becky who can guide the procedure and Edwin. But in the real world, it's not always so much like that. So what do you guys think the future will be? Because a lot of it has to do with data generation, and if TRISCEND-2 happens to be positive at 1 year, you know, it's just human nature. People are going to swing towards that. But I do agree with you, Howard. Like, in the end, a good repair is better than a replacement. We just have to get there quickly.
Just to follow up on that briefly, you know, there are cases we all look at and say, this is a 3-hour, 4-hour, 3-clip case, and we're going to end up with moderate TR. And then there are other cases we look at, like the one Nita showed earlier today, where you kind of know where you're going to put your clips. You figure you can put 2 or 3 in pretty quickly and get excellent results. So I think, you know, taking anatomy out of the equation isn't a good idea. We have to look at the patient, and in our own minds, I think, you know, a third of the time we look at them and say, there's no way I'm going to be able to get a good result here. Let's put a valve in and be out fast. And then there are other patients we look at and say, we can do this with a clip. And then there's some in the middle that we're not sure that anything's going to really work well. And they may not be good candidates for either therapy right now, and we need some better options like annuloplasty plus clip or annuloplasty alone. And so I think it's going to be less of a 2/3, 1/3, as you suggested, and more of a 1/3, 1/3, and I'm not sure yet about the third, and that we need other options.
If we had an effective and quick annuloplasty, it would be probably preferred. There are some centers in Germany that use Cardioband as their workhorse device, but they're outliers. Okay, Anita, what do you think?
Oh, I was actually going to throw this out to Greg, because one of the things is, you know, we learned that repair was better than replacement for the mitral side because we have data that. Do we need data then to look at tricuspid repair versus replacement? Because there's trade-offs, right? One is not perfect to the other. And patient selection, we can use our bias and our personal experience, but don't we need data? Because right now it's a data-free space, you know?
Yeah, I mean, in general, yes, unless the individual registries are so obvious that one is better than the other. And that could be the case, because unlike the mitrals, where TEER is pretty effective at now getting down to 1+ or less, you know, again, TR can be so profound that you may not be able to get as close with TEER. Mm-hmm. So I'm very excited to see what the results of the TRISCEND randomized trial are going to be and where the next TEER studies go.
I think for a randomized study of TEER versus TTVR, it's going to take a lot of follow-up in a large study that may be just prohibitive. Yeah. I mean, if we take the numbers from TRILUMINATE, if it's a 1-year mortality of 8%, we'd have to do a several multi-year study. And the analysis from Suzanne's data, remember, that's 400 patients. And it's also exploratory, so you're going to have to get a larger number to make sure you have the power. And it's just going to take a longer study. And I would love to see it. I just don't know if it's going to be possible. So.
I also think it's hard to randomize patients if they all have different anatomies and different success rates with each procedure, and their age and their risk factors. I mean, you may not want to put a valve replacement in a 60-year-old, you know, and you may not want to do a, you know, there's different things for a 60-year-old, a 90-year-old, good anatomy, bad anatomy for one procedure versus the other, and it's hard to get that all figured out in a smallish randomized trial. I think that's part of the problem with primary MR and some of the other MR trials. They're mixing lots of patient populations together.
Let's make one other comment. Can you hear okay?
Yeah.
You're not going to reduce mortality, and probably not even heart failure hospitalizations, if you enroll just the low-risk patients that you did in TRILUMINATE. Yeah. You enrolled patients without left-sided valve disease and with normal RV function for the most part in TRILUMINATE. Imagine COAPT if we enrolled normal LV function. We wouldn't have shown anything. So these patients are always going to have a prognosis benefit in the sicker patients. Yeah. And I know there was a lot of concern about overloading the right ventricle, et cetera. Well, we had the same concerns about overloading the left ventricle by fixing MR, but the forward cardiac output takes care of that problem. And you'll have the same thing on the right side. So you've got to enroll sicker patients.
And you need long-term follow-up for replacement complications. They're different than repair complications. You know, they're not going to show up at the 1-month outcome of TR reduction.
I mean, we enrolled what we could, you know, because these are patients who had to be anatomically suitable. You know, if they had blown out RVs with large gaps, they're just not going to get enrolled because they can't get treated. And so, so we enrolled who we could. I'll tell you, at least at 1 year, there was not one iota of a difference between mortality or outcomes between the heart events for the different grades of TR, residual TR. And so it's going to take multiple years. We just don't know whether it's 2, 3, or 5 years. Yeah. So I gotta believe as a physician that symptomatic torrential anything is going to harm a patient at some point. It's just not at 1 year. So.
But only thing is we were a little concerned. I mean, everybody wanted to try to be positive, understand mortality. But what about the heart failure hospitalization? At least that is not even affected at all, right? I mean, that's any explanation for it? I know I spoke to David also, Adams.
I mean, it's funny. David doesn't seem to be as surprised either. He wasn't surprised by mortality, and we were like, why are you not surprised? Well, and when I look at our patients, yeah, some come in for TR, for HFH, but a lot of our HFH patients, they are left-sided driven. And I think patients, when they have swollen legs, they tend to call their doctor and go to clinic. Whereas when patients are in the left-side equivalent of pulmonary edema, they come to the hospital. So it's just a little bit different. Yeah. Oh, I didn't mean to speak for David here.
Yeah.
I know that was tongue-in-cheek about how long it took you, but if we had that attitude, there would never be mitral valve repair. Mitral valve repair, always, I can teach anyone in this panel right here to do a mitral valve replacement in 2 months if you come scrub with me. I cannot teach you how to do a mitral valve repair in 2 months. So we can always say it's fast for us. The question is what's best for the patient. So, and you're not on bypass and your heart's not ischemic, so break a leg, take 3 hours and preserve the valve if you can. You're not hurting the patient. Having said that, I think that, we just always go back to the guidelines. I keep reminding people every time we talk about this topic, there is no indication in the guideline, American or European, that suggests tricuspid intervention to decrease mortality. The evidence doesn't exist. So I don't know, we just sort of all of us got bamboozled into this left-sided valve disease and started talking about mortality as endpoints. It's such a short time interval. That can't happen. What Paul said is true. We know massive torrential, any valve, AV, right or left, eventually has a survival penalty or event-free survival penalty. So long-term, that will have an impact. And just watching both of these, I'm not sure I'm ready to say the safety profile is the same. I realize it's early, there'll be iterations. I've heard some pretty high up people at the company that made this valve, they think they need a different valve. So if the question's between this technology and TEER, I'm going to vote for TEER. Show me some different technology with a more suitable safety profile, then I think it will work. But what Howie said is correct. One day, imaging will help the team decide which one to try first. And you will do a clip and preserve valves when the patients are suitable, and you assume you can get to at least moderate, and more likely sooner than later it will all be mild or less for those patients you're selecting. And then there'll be groups of patients, like Paul said, that, or what Neil said, whether you're going to be doing a replacement if you're going to do it with a catheter, then there will be some gray zone. That's probably where your comfort zone will happen. But I don't think it's obvious at all, as it might have been a year ago, which one of these is going to be the dominant treatment the next 2 or 3 years. I think one thing that's for sure is surgeons will all support it, because I don't think this is a population that anyone really wants to operate on.
All right, I think great session. And of course,